We're going to look at anemias that are caused by defects of the DNA metabolism. Right, so the root cause of megaloblastic anemia is from impaired DNA synthesis. So we have the physiological roles of vitamin B12. So vitamin B12 does DNA synthesis. It is essential for the formation of DNA during cell division. It also helps in red blood cell formation, so it helps prevent megaloblastic anemias. It also has a role in the nervous system function. It maintains the myelin sheath and can help support nerve health. Also plays a role in the homocysteine metabolism, which works with folate to convert homocysteine to methionine. So let me talk about the folate physiological role. So it plays a role in the DNA and RNA synthesis, which is crucial for cell division and growth, especially during pregnancies, which is why they recommend taking a folate supplement. Also plays a role in the red blood cell production, which prevents, again, megaloblastic anemias. Plays a role in the neural tube development, which is key in early fetal development to prevent neural tube defects. Homocysteine metabolism as well, so it works with the vitamin B12 to lower homocysteine levels. So vitamin B12 and folate work together in DNA synthesis and homocysteine metabolism. Folate actually donates a methyl group, and vitamin B12 helps transfer it to convert homocysteine into methionine. This process is essential for cell division and red blood cell formation, and also helps with the nervous system health. So without vitamin B12, folate will become trapped and it couldn't function properly, which leads to anemia and other health issues. So a defect in megaloblastic anemia, so both vitamin B12 and folate are essential for this, as mentioned earlier. So that is essential for proper DNA synthesis in developing cells, particularly those red blood cell precursors in the bone marrow. Deficiency or dysfunction of either can lead to a defective DNA synthesis. So the pathophysiology, so the impaired DNA synthesis causes abnormal development of those erythroid precursor cells called megaloblasts in the bone marrow. Megaloblasts have nuclear maturation defects while cytoplasmic maturation continues, leading to a characteristic nuclear cytoplasmic asynchrony. These abnormal megaloblasts fail to reproduce normally, which results in reduced production of mature red blood cells. The outcome is ineffective erythropoiesis and anemia. So in summary, real quick, we have megaloblastic anemia can arise primarily from vitamin B12 or folate deficiency, impairing DNA synthesis, and that leads to abnormal large erythroid precursor called megaloblasts and decreased red blood cell production. Some other causes of megaloblastosis can occur in myelodysplastic syndrome. This is a group of bone marrow disorders that are characterized by ineffective hematopoiesis and dysplastic changes in blood cells, including megaloblast-like changes in the erythroid precursors. It could also be caused by congenital dyserythropoietic anemia. This is a rare inherited disorder that causes defective erythropoiesis with characteristic multinucleated erythroblast and megaloblastoid changes. Other cause of megaloblastosis is acute erythroid leukemia. This is a subtype of acute myeloid leukemia involving malignant proliferation of erythroid precursors, often showing megaloblastic morphology. So just a quick summary of this slide is we have a megaloblastosis is not exclusive to vitamin deficiencies, but can also be seen in certain hematologic disorders like myelodysplastic syndrome due to abnormal erythroid precursor development. Some general symptoms that are common to both vitamin B12 and folate deficiency is fatigue. You're going to hear that one a lot. Weakness, shortness of breath, an inflamed tongue, nausea, and constipation. Some vitamin B12 deficiency specific symptoms would be memory loss, having peripheral neuropathy like numbness or tingling in the toes and fingers, having a loss of balance, maybe even having some personality changes or psychosis. For folate deficiency specific symptoms, we have depression, neuropathy, and psychosis. So megaloblastic anemia presents with general symptoms like fatigue and weakness. Neurologic and psychiatric symptoms such as neuropathy and psychosis are more prominent in vitamin B12 deficiency, but could also occur with folate deficiency. Some causes of folate deficiency could be from inadequate intake, so if they have poor dietary consumption of folate-rich foods, Could be an increased need, such as times like pregnancy and lactation, or even in infants and children during their growth spurts. Could be impaired absorption, so they could have a rare autosomal recessive deficiency of the proton-coupled folate transporter, which could lead to a severely decreased intestinal folate absorption. Could also be from impaired use, so there are certain drugs that can interfere with folate metabolism, and this includes antibacterial agents and even some anti-seizure medications. Could be because they're having excessive loss of folate, and this could be an increased folate loss through their kidneys, which is actually pretty common in dialysis patients. For vitamin B12 deficiency causes, it could be, again, inadequate intake. So this is common in vegans who do not consume meat, eggs, or dairy products. Could be, again, at times during an increased need, such as pregnancy and lactation, and during those growth spurts in children. Could be from impaired absorption, so it could be failure to separate vitamin B12 from food proteins in the stomach. Could be from failure to separate vitamin B12 from haptocorin, which is a binding protein. Could be a lack of intrinsic factor, and that's usually due to an autoimmune disease, and that could lead to pernicious anemia, which could be from an intrinsic factor deficiency, which leads to poor vitamin B12 absorption. Could also be from an infection with Helicobacter pylori or H. pylori, and it can interfere with absorption. Malabsorption syndromes can also be a cause, such as celiac disease and inflammatory bowel disease. We also have certain inherited disorders that can affect vitamin B12 absorption and transport, such as the Ehlers-Danlos syndrome. We also could be something where they're competing for vitamin B12, like if there are certain parasites like a tapeworm or certain bacterial infections can compete for your vitamin B12. For laboratory diagnosis, we're going to perform some screening tests for vitamin B12 deficiency and megaloblastic anemia. We're going to start with the CBC, or that complete blood count and reticulocyte count. Lots of times we're going to see a decreased hemoglobin, hematocrit. We're going to see a pancytopenia, which is the reduction in all blood cell types. We're going to see reticulocytopenia as well, which means a low reticulocyte count, which can indicate a decrease in red blood cell production. We may see, or probably will see, an increased MCV, or mean corpuscular volume, which will lead to a macrocytosis. We could even see an increased MCH, which is that mean corpuscular hemoglobin. We'll probably see an increased RDW, red cell distribution width, as well, which would show that there is variability in red blood cell size. Lots of times the MCHC, or the mean corpuscular hemoglobin concentration, will be normal. In the blood smear examination for red blood cells, we're going to usually see ovalocytes, so those oval macrocytes. We're going to see teardrop cells, red blood cell fragments, and microspherocytes. For white blood cell manuals differential, we're going to see hypersegmented neutrophils. So these are neutrophils with 6 or more nuclear lobes. We're also going to run a bilirubin and a lactate dehydrogenase test, or an LDH. Both of these are increased, which can reflect increased red blood cell breakdown or hemolysis in megaloblastic anemia. For the bone marrow examination, this will show characteristic megaloblastosis. We're going to have large, immature, nucleated erythroid precursors with abnormal nuclear cytoplasmic maturation. For folate and vitamin B12 levels, you're going to have a direct measurement of serum folate and vitamin B12, and that will determine the deficiency of which one is lower. You can do a methylmalonic acid, or an MMA, and homocysteine level. So the methylmalonic acid, you'll have an elevated, or it will be elevated, in vitamin B12 deficiency, and this is actually a specific marker for vitamin B12 deficiency. Now, the homocysteine level will be elevated in both vitamin B12 and folate deficiencies. For the antibody assay, we would detect autoantibodies that could be associated with pernicious anemia, such as anti-intrinsic factor antibodies and anti-parietal cells antibodies. We could also do a stool analysis for parasites. So this would help to rule out a parasitic infection, like we mentioned earlier, like a tapeworm, that can cause vitamin B12 deficiency through, their competition or malabsorption. They are trying to take our vitamins from us. Macrocytic non-megaloblastic anemias. So by definition, macrocytic anemias, this is where the DNA synthesis is unimpaired. So the red blood cells are larger than normal, hence the name macrocytic, but there is no defect in nuclear maturation. So the MC values, or MCV values, it's a mild macrocytosis, so it's a slightly elevated, usually not too crazy. And in the peripheral blood smear, we're not going to see hypersegmented neutrophils like we saw in megaloblastic anemia. We're not going to see those oval macrocytes. The red cells are actually going to appear round and large. The bone marrow evaluation, you're going to have no megaloblasts seen, and erythroid precursors are actually going to appear normal. So the causes of macrocytic non-megaloblastic anemias could be from liver disease such as cirrhosis, chronic alcoholism, bone marrow failure like aplastic anemias, and even in reticulocytosis, it could be from increased immature red blood cells, which tend to be larger. For treatment of megaloblastic anemia, it actually addresses the specific vitamin deficiency that's causing the anemia. So vitamins for treatment, we would do, depending on what's causing it, a vitamin B12 supplement or a folic acid supplement. The body's response time, so prompt response is expected if treatment is correct and started timely. Improvement in symptoms and blood counts will usually be noticeable within days to weeks. So luckily it's, as long as you treat it the right way, it's going to usually correct itself. This is just an algorithm for the preliminary investigation of macrocytic anemias and how you would break down and know which is which.